Hello there, I'm Mike Slade from the University of Nottingham in England. It's an honour to be presenting at your international conference on co-production and recovery, and I'm just sorry that I can't be there with you in person with my Hong Kong colleagues and friends. So I hope you enjoy my talk, which is trying to give a perspective on recovery that is global rather than solely national. So here's my talk. So I'm going to talk about best practice in recovery-oriented services and really try, as I say, trying to take a very global perspective. And the exciting thing is there is a lot globally that has happened in the last decade. So, for example, the World Health Organization issued its guidance on community mental health services. So this document, which we're looking at, is free to download, and the 7 technical packages shown on the right are also separate documents, again, free to download, which provide a really international perspective on the different meaning of rights-oriented, recovery-focused, person-centered, community-based mental health services around the world, identifying both points of commonality and culturally based differences. Now, similarly, the Comprehensive Mental Health Action Plan from the World Health Organization provides a global orientation towards rights, culture, and recovery, with an intention of supporting people to participate fully. And one of the areas that it has a focus on, which to some extent I understand applies somewhat in Hong Kong, is around issues relating to stigma and discrimination, which is a topic that I'll turn back to later in my talk when I talk about people using their own lived experience. A related tool is the World Health Organization Quality Rights e-training, and this is for a very high quality educational offer which is available in multiple languages based on the quality rights work from the WHO around supporting the implementation of the Convention on the Rights of Persons with Disabilities. So CRPD legislation is a human rights treaty that both the UK and China have signed up to and ratified, but in common with nearly all countries in the world, not yet fully implemented. So I commend this training. I've done it and learned a lot from it. I commend this training to you as an opportunity for you individually to learn more about what supporting rights and recovery means in a mental health system. The target for this training is an ambitious 5 million people to have completed it by the end of next year. So as you can see, this is a truly global endeavor. So moving from the multinational to individual country level, many countries beyond the high income Western countries have really engaged with trying to work out what recovery orientation means in practice. And that's spanning both policy guidance and practice guidelines for mental health workers in terms of how they can support the recovery journey of people that they are working with. So, for example, in Hong Kong, there is a clear statement that the mission of the service framework is to support recovery of severely mentally ill patients. And a particular focus is on providing both them and their families with help and support. So some of the core values that are identified, which again relate globally as well as nationally, are hope and autonomy and opportunity. So what are the things that are emerging internationally that are the vehicles of delivering this agreed mission of supporting people's journey of mental health recovery? Well, as you will very well know, one of the emerging innovations is called recovery colleges. So I've very much enjoyed following the journey of the Mindset Recovery College, but you will know that you are part of a broader community. So this paper in psychiatric services is looking at 10 years of research into what happens in and what are the impacts of recovery colleges on the lives of people who are using them as students. And they found good evidence for a range of beneficial outcomes, including satisfaction, and that's frankly not to be underrated when you compare with the satisfaction of people with mental health issues in using traditional mental health services, but also practical attainment of their recovery-related goals, changing service providers, so an impact on staff, and a beneficial impact on the need for wider services and therefore a reduction in service costs. So there's been a range of research, but one of the challenges is that it hasn't perhaps been of the highest quality. So there's a large number of smaller, not very well-funded studies that have been undertaken. So we've developed a research program in my research group called Recollect, and this is a program that's been going on since 2016, and one of the things that we've been very interested in doing good quality research on is what is a recovery college. Now, the scientific terminology for that question is about fidelity. So we developed what we call the Recollect fidelity measure. So this is a measure of how much a particular organization or service is a recovery college. How did we develop it? So we firstly conducted a systematized review looking at available publications that have thoughtfully presented about the key components of recovery colleges. We then undertook an international consultation with 77 experts around the world. We then interviewed 10 college managers in England, and we also interviewed 44 people who are students or peer or non-peer trainers or other managers at recovery colleges in England. And then finally, we tested the measure in 39 colleges across England. So this is what the fidelity measure contains. We identified 12 components that seem to be central to how recovery colleges work. So the first 7 are things essentially that you want more of. We know that we want more of valuing equality, a focus on adult learning, a focus on co-production, and so forth. The last 5, items 8 to 12 shown here, are different. They're where we identified variations. So for example, for item 8, we found pretty much all colleges say they are available to all. But when we went under the surface, we found for some colleges that means available to anyone who is using mental health services or works in mental health services or a carer of someone using mental health services. Whereas in other colleges, we found when they said available to all, they meant available to all, literally anyone from the community, whether they're connected with a mental health system or not, can make use of the college. So we identified 5 components that there seem to be 2 categories of, and for each of them, we don't know which is better. They may be equivalent, they may be more context dependent. So for the modifiable components, we just identify where the college is in terms of those differences on those 5 last items. So for the first 7 items, the score is 0, 1 or 2 for each of them. So the highest fidelity score you can get is 14 and the lowest is 0. And that gives some indication of fidelity to being a recovery college. So as I say, we then evaluated it. Now, I show this partly to pull out a couple of results that we had. One is if you look at the element called discriminant validity, we could tell the difference between clinician-delivered psychoeducational courses delivered in a traditional mental health system and a recovery college. We could also tell the difference between an adult education college, which in England would be a mainstream education college for people with no connection to the mental health system, and a recovery college. And again, the fidelity measure was able to tell the difference. So a second element to look at here is the last item, the item hierarchy. And here we identified that statistically, so we're not here making an ideological statement, but statistically, learning and co-production emerged as the 2 key foundational elements of a recovery college. So put bluntly, if you haven't got a focus on adult learning, and if you haven't got co-production, you probably haven't got a recovery college. Now, the other element I wanted to highlight here is that we did good quality science, and you may sometimes hear it said that recovery college and medicine and mental health are two separate worlds, that the two worlds don't cross, and that recovery is an ideology and clinical work is based on scientific evidence. That is just not true. You can do very strong scientific research relating to recovery, and that's what we published in the Canadian Journal of Psychiatry. And this is a psychometric paper about the Recollect Fidelity measure, and essentially demonstrating that it's can be defended for use in service settings. And if you want to look at it, you can download it from the website shown at the bottom. Alongside this work, we also looked at how recovery colleges work. So I'm not going to spend as much time on this, but we identified change mechanisms that can occur within a recovery college, and those are shown in blue. So you can see some of the key things are about relationships, about the environment, about explicit consideration of issues of power, and about supporting the individual to grow. So again, this is one of the key defining differences. A traditional mental health service tries to get rid of problems. A recovery college, in line with other recovery-oriented interventions, tries to increase strengths. And the outcomes can be both changes for the person, the student themselves, but also changes in their life. And if you want to read more about the impact on students, the reference is given at the bottom. Similarly, we looked at the impact of colleges on the wider environment. We picked out three groups. For staff, so mental health staff who may be working in the recovery college as a non-peer trainer with a peer trainer, or for mental health staff who may choose to attend a course as a student, the experience had an impact on their wider relationships with service users when they were back in their mental health service. So staff were saying things like, this was the first time I really understood what shared decision making means. So there was a discernible impact on professional practice. Secondly, at a wider level, within mental health services, the existence of a recovery college provides a space in which the traditional mental health system, the workers and teams in it, can experience an alternative culture. So the kind of feedback we were hearing was this was impacting on the understanding of co-production within the traditional service. So seeing co-production in a more radical way operating in a recovery college then changed the understanding that was used when services were talking about using co-production in their work. And then leaning away from the mental health system and towards wider society, there was also an impact that could be seen there in terms of people learning alongside the recovery college student. So for some people, this might be a first experience of meeting someone with a particular diagnosis. So that had a beneficial impact on community attitudes in terms of reduced stigma and likely discrimination. So that's something about work we've done on how recovery colleges work and what a recovery college is. The first recovery college opened about 13 years ago in England, so that's to say the first thing with the name recovery college on the door. But you will know that there are many recovery colleges now in many countries. So not just in your country and mine, but other countries around the world. So for example, this is Africa's first recovery college, which is in Butabika Hospital in Kampala in Uganda. I attended a course there, and the course was on understanding recovery. And I have to say, some of the stuff I was familiar with, some of the stuff I was entirely blown away by just how different the understanding of recovery was when translated into that cultural setting. So I think there is a lot to learn across different cultures. And of course, that relates to Hong Kong. So this paper, for example, looking at the experience of recovery amongst people from Hong Kong, identified the need to focus more on issues relating to self-stigma and improving self-worth than seem to be needed in other settings where research into people's experience of recovery had been conducted. So there clearly are a range of cultural influences, both on how recovery is understood and supported, but also therefore on the services like recovery colleges, which seek to support that recovery. So it made sense to us to look to try and understand things globally. So we've conducted the Recollect global survey as part of our Recollect programme of work on recovery colleges. We were reasonably sure, and this proved to be the case, that there were most recovery colleges in England. So we started with an England-wide survey of recovery colleges. We conducted this in 2021, and the paper on it has just come out. So this paper, we identified that in 2021, when we did the survey, there were 88 recovery colleges in England. Of those, we managed to involve 63, so 72% of them in our survey. One of the things we were interested in was fidelity, so we assessed all the participating colleges in terms of the Recollect fidelity measure, and fidelity was quite high. We also were able to understand their staffing, their workforce, the costs and the wider impact of the colleges on the mental health and social care ecology. So that paper is available to read now for further information. So building on that survey just based in England, we then last year conducted a global survey. So that's to say we went out to all the countries in the world. We used a range of sampling approaches to try to identify all the recovery colleges that currently exist. And the headline figure is that we believe that last year there were 221 recovery colleges in the world. So that's including England, 221 spread across 28 countries. So from a start, as I say, just over a decade ago, recovery colleges truly have become a global innovation. Now, in terms of the number of colleges in each country and each continent, I show them here. As you can see, Africa has, as a continent, got least, and Europe has got most. The countries with the most colleges are England, Canada with 23, and Belgium with 14. But in Asia, we identified, I say 15, sorry, I suddenly realized that should be 13, sorry, recovery colleges, and 2 in Hong Kong, 9 in Japan, and 2 in Thailand. So we were interested in cross-cultural differences, and although we're still exploring the data and we haven't yet published, one thing that seems to have emerged is that there are differences between Asia and England. So looking at all the colleges in Asia, comparing them with the ones in England, we found that the scores on fidelity, the overall fidelity measure score, were in general lower in Asia. And we were very interested in why that should be. So we looked in more detail, and the 2 items that seem to be consistently scored lower in Asia are co-production and tailored to the student. So we planned future research to look at, is this what's called a self-enhancement effect, which means that actually the fidelity is truly the same, but it's a measurement difference that people in rating co-production in England tend to rate the same level of co-production higher compared to people in Asia rating co-production. So it may be that it's a measurement problem, or it may be that there is a genuine difference in terms of the value put on tailoring to the student being higher, and therefore more effort being put into it in more individualistic societies like England compared to more collectivist societies. So we're developing a program of work looking at the cultural differences and how they impact on recovery colleges. So let's go more widely than recovery colleges now to talk about the topic of peer support. So mental health peer support, involving people who have their own experience of mental health and recovery in providing support to others as credible role models of recovery, is of course now a global endeavour, well established in Hong Kong as well as many other countries. The most recent meta-analysis looked at all of the randomized controlled trials that have been published. So in their systematic review, these authors in 2020 found 19 randomized controlled trials from around the world that have been published. And when you put the data, the findings from all those together in a meta-analysis, they found that trial participants, people receiving one-to-one peer support, did indeed experience improvements in empowerment and recovery compared to those who didn't. So the message is very clear that mental health peer support work as a general approach is effective in supporting recovery. However, one of the limitations of this study is that it could only use the data that's been published. And the randomized controlled trials that have been published have all come from what's been called the global north. So Western Europe, North America, Japan, and Australia. So that's clearly a limiting factor when we want to know the impact of peer support work in other settings, and also how peer support work should be modified in other settings in ways that might have relevance for the global north. So the UPSIDE study is in addressing this issue. So UPSIDE is taking place as we speak. In fact, it's been extended now to 2023. And UPSIDES is funded by the European Union to understand peer support work in lower and middle and higher income countries. So to compare outcomes for people who are students at, people who are receiving mental health peer support work across a different range of income settings for different countries. So when we started UPSIDES, we tried to understand what kind of modifications are used in providing mental health peer support work, and we found quite a wide range, including those that are modified because of different socioeconomic issues. So there isn't the money to provide one particular approach that's modified in a different way. Organizational needs differ across different countries, and the overarching goal is modifications in order to provide the best possible support for recovery. So we identified, shown on the left, the types of elements of peer support work that get modified. So as I said, this is the places where the existing randomized controlled trial evidence has come from. And in UPSIDES, we're collecting evidence in new places. So in Uganda and Tanzania, in Africa, and also in India, in Israel, and in Germany. So the UPSIDES intervention is testing the manualized intervention of peer support work, which is shown on the left, and you can download the intervention manual from the website shown, and then testing it in a randomized controlled trial. So we're randomly allocating people in 6 sites across 5 countries to either receiving peer support work immediately or receiving it after a 1-year wait, and comparing the outcomes across that year for the 2 groups. So we're in the process of analysing the data for that, and we hope to be submitting the first lower and middle income peer support worker randomised control trial later in 2023. A second strand of work that we've been developing in our research group is called NEON. So NEON stands for Narrative Experiences Online. And essentially, NEON is a research program with 3 goals. The first is to create the world's largest collection of recorded stories of recovery. So here we're particularly interested in things like books or other forms of text, but it may also be videos, or it may be podcasts, people in various ways describing and talking about their experience of mental health recovery. Secondly, the goal is to develop an interface using an artificial intelligence approach called machine learning to match people to individual stories that may be most likely to benefit them. And thirdly, to conduct randomized control trials to try to understand, does exposure to another person's recovery story have a beneficial impact? So underpinning all this is the central idea that we are changed by stories. And if we're smart about what stories we choose to give to a person, we can be more likely to create beneficial change in their life. So NEON has been going on since 2017. And the first question we had to grapple with is, well, what do we mean by a recovery narrative? So we've identified that there are 5 key components of a story that makes it a recovery narrative. The first is that it's told by the person, the individual themselves affected by these experiences, not by a member of staff or not by their family member, for example. The second is that the story must include both difficulties, adversity or struggle, and overcoming, some sense of strength or success, or even just survival. So a recovery story doesn't have to be things were very difficult and now they're wonderful. It may be that things were a bit difficult and they're still a bit difficult. So we wanted to include a wide range of stories with different balances between adversity and overcoming. They must, at least in part, but not necessarily in whole, be related to mental health challenges. Otherwise, they're not a mental health recovery narrative. But we're very aware of intersectional issues that for an individual, the mental health part of their difficulties may be a large part or maybe a small part of the overall challenges, and other forms of stigma or discrimination related to other aspects of identity may be more relevant to that particular person. And then finally, the story must relate to events over time, and the story can be loosely told or can be very chronological, but there must be some sense of a transition. So as I say, it can be a written story, it can be a video, someone telling their story, it can be a podcast, but sometimes it can be a picture. So here, for example, is a recovery story. So this is a story of someone with an albatross around their neck, which they embrace and then set free to fly. I find this story very moving. So we created the world's largest collection of stories called the Neon Collection, and then used the Neon Collection as the basis for a new intervention called the Neon Intervention. So we've evaluated it in randomized controlled trials, which I'll come to in a moment. And this is for the people who took part in the study. This is the first page they access. So as you can see on the right, there are various things that are done to enhance the trustworthiness and engagement with this digital health intervention, which is fully delivered online. So there are videos about how to use the intervention. There are testimonials from people who have used it, and then there's information about people like myself and other team members who are behind the Neon team, behind the Neon intervention. So when you get to use the intervention after you've signed up to the trial and been randomized to the intervention arm, this is the page that you see, and it's got two major parts to it. So the top section is different approaches to choosing a story. So the top button, if you click on match me to a story, uses what's called a recommender system to identify, based on characteristics of you and based on characteristics of the stories, a story that might be particularly helpful to you. So the intervention matches you to a story. Or you might not want that. You might just want a random story, in which case the system will choose one of the 700 or more stories from the Neon collection and give access to that. Or it might be that you want to browse different types of stories, for example, stories about people with a particular diagnosis or a particular experience of services or a particular demographic characteristic. So you can do that with the Browse Stories button. Or in My Stories, you can access those stories that you previously bookmarked or rated as hope promoting for you. And then below is information that we use gamification approaches, so collecting badges, and also we have an opportunity for the participant to update their profile so that a better matching can be made by the recommender system. So the Neon trials have been where we've been investigating the impact of the Neon intervention on people who are using it. The development of the intervention and the trial design are described here. But essentially from 2022, for the last 2 years, we managed to begin the week that COVID hit. So we were very pleased that we had an online intervention across all of England, and by engaging with over 800 community organisations, we've run 3 randomised controlled trials. So the Neon trial is for people who live with experiences of psychosis, and around 740 people took part in that. The Neon O trial is for people with any other form of mental health issue other than psychosis, and over 1,000 people from across England took part in that. And then the Neon C trial is for informal carers. This was a smaller exploratory trial which showed a positive impact. We believe, for example, it was helpful to informal carers in there making sense of the experience and experiencing more hope. So that will lead to a future larger trial. So in terms of the Neon trial and the Neon O trial, we're almost but not quite at the point of having results that we can feel are robust. And again, later in this year, in 2023, we hope to be submitting these for publication, and we hope that the neon intervention will become a widely used resource, which is also translated into and used in other settings, where, especially those, for example, where stigma and discrimination may be a particular challenge. So that's all I've got to say. I thank you very much for your attention. I hope you've enjoyed a sense of both the foundational work that recovery colleges are building on in terms of the global consensus on recovery, and also a sense of the exciting new emerging science that's taking place in this setting. So thank you very much for listening, and I hope you have a wonderful rest of conference. Thank you now.